Now, osteotomy around the knee, when, where, and how. When in terms of indication, where is it high tibial or distal femoral osteotomy, and how to plan and how to do it. Before just starting, if you have this patient, 48 years old, he has pain, not responding to conservative treatment, he has this mild to moderate osteoarthrosis, what would you do? Who would continue conservative treatment? Conservative. Who would do arthroscopy to drive? No one. Who would do total knee replacement justified by severe symptoms? Anyone? Who would do osteotomy? Perfect. Now, osteotomy around the knee, when? Many indications. First, to correct deformity, to offload a diseased compartment, to stop or off-stretching a diseased ligament, especially in the posterior corner, and also we have combined indications like valves and instability or osteoarthrosis and instability and so on. So the indication decides the plan, so where to shift the mechanical axis, whether to correct or to overcorrect, this is important. In case of deformity, we correct, so we shift the mechanical axis to the normal or neutral axis, but we should avoid hidden deformity. And you see in this example, the left limb looks straight, but the surgeon corrects all the deformity from below the knee, high tibia, and you see there is an oblique joint line, and this is a hidden deformity, and we know this oblique joint line will increase the shearing forces and may lead to osteoarthrosis. So where to do it? High tibial, double, distal femoral, this is according to your plan, so always do a plan. This is a case where this is a valve deformity, and you see where to do the osteotomy. Again, plan, and from this measurement it seems that it's a femoral deformity. So we correct by distal femoral osteotomy, this is the plan. This is some surgical tips. We start with guide wire, make the measurement, make the first cut, the second wire, take the wedge out, weaken a little bit the hinge, but preserve the hinge, and after that, gradual correction and closure of the osteotomy, and after that, check alignment and fixation. And you see here, this is fixation. Before, this is plan, this is after, and we'll do biplanar osteotomy, and we'll talk about the benefit of biplanar osteotomy later. This is before and after. This is another case valves, but here, the deformity, it looks from the measurement that is double deformity, high tibia and distal femur. So in these cases, we plan for double osteotomy, and this is the surgery, and this is after. What not to miss? This patient has a valve deformity, but what not to miss? The sagittal plane deformity, and this is important because if you have such slope, increased tibial slope, you will have maybe failure of ACL reconstruction. So this should not be missed. So this is a case where we plan for correction of the slope and the valve deformity. So we did our measurement, our plan, and again draw it and make what we call it biplanar, double wedge, bidirectional osteotomy. And here we do what we planned. Go to the theater, make the cuts, close the wedge, and this is how the slope is corrected. So it's not only high tibia or distal femoral, we can do even more complex osteotomy like intra-articular osteotomy, and this is a case of Plown's disease with paradoxical valgus deformity at the femur. And you see here, the femur is valgus and severe deformity of the tibia. So what we did, we planned, always plan, correction of deformity, went to the theater, we did hemiepiphysiodesis for the femur to correct the valgus, and we did intra-articular osteotomy. This was the first stage, and after that, this is after the first stage, after that we did the second stage, closing wedge osteotomy. And you see here how after the surgery. This is before, after the first stage, and after the second stage. So we have to do always planning to correct this deformity. The other indication is offloading a diseased compartment. What's the disease? Osteoarthrosis, chondral lesion, pain after meniscectomy. Who see a lot of cases of knee pain after meniscectomy? Yes, I see a lot of these patients. So a lot of other cases like osteonecrosis, or protect your meniscus repair, or chondral transplant, or meniscal transplant. So we have a lot of indications for osteotomy. In cases of knee osteoarthrosis, who's the ideal patient? Young patient, heavy worker or has sports activity, mild or moderate osteoarthrosis, and has undesirable malalignment. So if the patient has medial osteoarthrosis and valgus, it's good. But if medial osteoarthrosis and varus, we have to correct this. So what's the relation of deformity with osteoarthrosis? We know from the literature that each 4 degrees of malalignment will increase the risk to develop osteoarthrosis by 3 times. And if it develops, there is a risk of progression by 10 to 20 times. So this is important. What happens if we do this, if we shift the mechanical axis from medial to lateral compartment? Many studies, this is one of the studies by Professor Philipp Lobenhofer and Jens Agnes Kirchner from Hanover. They found that if the line is at the 0 line, which is the most medial part of the tibia, of the knee, the load would be 2/3 on the medial side, around 2/3. And if we shift it to the yellow line, what's called the Fujisawa point, the load would be the other way, 2/3 on, around 2/3 on the lateral. So by doing osteotomy, we are unloading the disease compartment, so this will reduce pain, slow the progression of osteoarthrosis, and delay the need for future total knee replacement. Arthroscopy, to do or not with osteotomy, I usually do it routine because I have something to do, like microfracture, treatment of chondral flaps, treatment of meniscus tear, and again, to check the lateral compartment. And not to miss root tear. This is commonly missed, unfortunately. So we have to check to probe the root, and if torn, we have to repair it. We have to check for the other compartment. And so you see, in this case, we did repair of the root, and this is common our practice to do root repair with osteotomy. And look, this is a 48 years old, like me, she's young. So what to do? She has root tear and osteoarthrosis. So in this case, we plan to repair the root, to do microfracture, and to do osteotomy. And look how the knee is after 15 months. And this is common in my practice, that when I preserve the meniscus, and I have talked about the meniscus after maybe 1 hour, when we preserve the meniscus, we see restoration of the joint space after the surgery. Look, this is another case. She's around 50 years old. She has extruded meniscus, advanced osteoarthrosis. She refused the idea of joint replacement. What we did mobilize the meniscus, reduce it, and do osteotomy. And look, after 5 months and 1 year. So osteotomy has a major role in treatment of these patients. So back to our case, what would you do? Osteotomy. I think most of you will agree to do osteotomy. Now, high tibial distal femoral, in this case, sure, after our plan, we did high tibial osteotomy, but not always high tibial. This is another case where she has bilateral osteoarthrosis. On the right side, we did double osteotomy, and the left side, we did high tibial osteotomy. And this is according to the plan. So this one case of combined deformity, because there is a varus and osteoarthrosis. Other indications of stretching a diseased ligament or stop stretching of that ligament. And this is important in the posterolateral corner. This is a case, this is basketball player. She has no trauma. She had progressive pain posterolateral at the knee. And when she come to our clinic, look to the gate, she has varus hyperextension thrust. And the Dale test was grade 2, so I don't think she will benefit from ligament reconstruction. So what we did, again, check the alignment. She has a mild varus. We correct the varus, but not overcorrect. And this is look to her gait after 5 months. Normal gait, no pain, and no thrust. So other indications for osteotomy in treatment of patellar instability, either to do rotational osteotomy of the femur, tibial to pelvic transfer, distal femoral osteotomy with or without tibial to pelvic transfer, and very interesting is to do rotational, what we call supratubercle osteotomy for the tibia. And this is a case of malalignment syndrome where we did derotational osteotomy for the femur and the tibia. And look, she has increased TTG distance and a severe external tibial torsion. And by doing that, the operation, we did biplanar supratubercle osteotomy. Look, we correct both the rotation and the TTG distance. So this is after, and again biplanar osteotomy. And I'll tell you about the benefit of that. So combined indication, this is a case of failed lateral ligament reconstruction. The patient has previous two surgery. He has medial osteoarthrosis, so this is ideal for osteotomy because by osteotomy we can offloading the medial compartment and stop stretching of the lateral compartment. This is what we have done, and this is the result. Even the patient didn't need ligament reconstruction. So is it high tibial to do high tibial or distal femur or closing wedge or open wedge osteotomy? Before we were doing the closing wedge, but it has many disadvantages like the need for fibular osteotomy, muscle dissection, the problem of the offset, which may interfere with later knee reconstruction, and most important, the peroneal nerve injury, which is more common in the literature, is more common than even you think or believe. Now, the open wedge osteotomy has many advantages, like we don't need to do fibular osteotomy or muscle detachment, no risk of peroneal nerve injury, no leg shortening, and we can do what we call it intra-op fine-tuning, so we can manipulate and fine-tune the correction intra-op. It has many problems before, but nowadays by the development of the technique, especially the biplanar technique, biplanar osteotomy in two plane, the gradual opening of the hinge, what we call it top to bone, just keep the hinge to cause plastic deformation, not to break the hinge, and also the use of plate fixator and locking plates, and the control of the slope changes by dividing the deep fibers of MCL. All these are development in the techniques. And look here, when doing biplanar osteotomy, look for the coronal plane osteotomy, and you see the red arrow. Healing, this is by Professor Philippe Lebenhofer. Healing was complete after 3 weeks only. So by this technique, even if we do more correction up to 16 millimeter, you didn't even need to put a graft. So if you know this technique and you follow these advanced principles and technique, so you can do different things. Like we allow patient for full weight bearing, and by this we can do bilateral osteotomy. We can do minimal invasive surgery like this. You can do even with small wounds, and you can think of osteotomy in different way. So if I ask you to plan correction of this deformity, most of you will say, okay, this is the corner, so we have to do like this. But the problem in this, you need fibular osteotomy, muscle dissection, break the hinge, and so on. So I would plan it like this. So by this, we preserve the hinge, take the wedge out, we preserve the hinge, we did closure, gradual closure of the osteotomy, check the alignment, then we compress, look here, we compress the hinge, this is the hinge is compressed, and we did biplanar osteotomy with the benefit of early healing. So again, this is the hinge compressed, so we can allow the patient full weight bearing, which we cannot, this is the post-op, and all these we cannot achieve if we plan this surgery like this. So by conclusion, osteotomy has an important role in the treatment of knee pathology, including osteoarthrosis and knee instability. Always do pre-operative planning to decide the site and degree of correction. Biplanar osteotomy is very useful improvement in the technique of osteotomy around the knee. And always when doing this technique, preserve the hinge as possible and respect and follow principles. Thank you. Dr. Ashraf.